If the previous documentation lectures have been putting you to sleep like this, doctor, hopefully this one will wake you up. Today, we're going to be talking about critical care documentation and reimbursement. By the end of this lecture, you should be able to answer the following questions. What is considered critical care? What is required for documentation? How is this different than a level 5 chart? And what are some common examples of critical care? Starting with the definition of critical care, this is the medical care provided to patients who have, quote, an illness or injury that acutely impairs one or more vital organ systems such that there is a high probability of imminent or life threatening deterioration in the patient's condition. In addition to your patient having a critical illness, you must show that you're doing critical interventions such that you are performing, quote, decision making of high complexity to assess, manipulate, and support vital organ system failure and or to prevent further life-threatening deterioration of the patient's condition. Another feature of critical care billing is that it's time-based. This is different than all other documentation that we've discussed so far, where time is not a factor. Those previous categories of COPA, data, and risk are not calculated here, but you still must document medical necessity for critical care billing. In addition, you need to provide at least 30 minutes of critical care time, or else your chart will be billed as a level 5 chart. The critical care time can be non-consecutive time, meaning you can add up all the care time delivered over multiple periods. To summarize, there are 3 things that need to be documented to bill for critical care. 1. You need to have a patient with a critical condition. 2. You need to perform critical interventions. And 3. You need to provide at least 30 minutes of direct patient care. You may be asking yourself what critical care time counts towards direct patient care. Well, obviously, if you're at the patient's bedside providing care, that counts. However, you have to exclude separately billed procedures. This means that the time spent performing endotracheal intubation, central line, arterial line, CPR, etc., is not counted as critical care time since you are already billing for this time with your procedure note. You must mentally subtract this procedure time from your overall critical care time. Reviewing test results counts towards direct patient care. Discussing patient care with consultants or staff actually counts as direct patient care. Documenting the medical record counts towards direct patient care. Also, discussing specific treatment issues with family members or surrogate decision makers when the patient is unable to provide history or make medical decision, that counts. But the time does not count if you are just informing the family of the patient's condition. Finally, time spent alone by the resident does not count towards critical care time. As for the actual wording you must document, I suggest you use some macro or smart phrase from your hospital that has been agreed upon by the leadership. It should include some of the details above, as well as the exact time for critical care, not a range of time. As I mentioned before, the big procedures don't count towards critical care time. Therefore, the time spent performing CPR is not counted towards critical care time. As an example, if a patient is brought into the ED in cardiac arrest and you perform 40 minutes of continuous CPR and pronounce the patient dead, you should bill for CPR plus a level 5 chart, but no critical care time. This is because CPR is technically a procedure, and you cannot bill for both the CPR procedure and critical care time. However, there are some EDs that may decide to skip the CPR procedure billing and only bill for 40 minutes of critical care time. But let's look at the difference in reimbursement for the two situations. In the situation where you bill for both CPR and a level 5 chart, that's a total of 10.6 RVUs. In the situation where you only bill for critical care, you obtain 6.36 RVUs. That's a 4.24 RVU difference, which means your ED lost 40% of revenue for the work you already performed. On a side note, both Medicare and CPT agree on the definition of critical care and what services should be included when reporting critical care time. However, currently Medicare and CPT disagree on how critical care time should be reported and billed beyond the initial 74 minutes. Since it is uncommon to provide over 74 minutes of critical care in the ED, I don't think this controversy is important to discuss here, but if you're interested, you can read more about it on the ACEP Critical Care FAQs, question number 5. The link is in the show notes. Moving on to some examples. Unfortunately, there are no dependable published lists of situations that are consistent with critical care, but after doing much research, I compiled my own list of some common critical care scenarios. I'm not going to go through all of them, but I will mention a few to demonstrate the nuance in each case. Acute coronary syndrome. So you can bill for critical care time in a type 1 NSTEMI with a positive troponin where you'll be given heparin. Now, clearly you can bill for STEMI, but the patient's usually not in the emergency department for greater than 30 minutes. So unless your patient's there for a long time, you can only bill a level 5 chart in a STEMI. A severe asthma exacerbation requiring continuous NEBS, also known as status asthmaticus, If the patient required continuous nebs or BiPAP or some additional medications, you can bill for critical care. Cardiac dysrhythmia, bradycardia, or tachycardia requiring emergency treatment. Now, if the patient has a heart rate of 110 and they're in sinus tach from pain and you give them fluids and some pain medication, that does not meet critical care definition since your patient was not critically ill. But if the patient was hypotensive and required atropine or epinephrine infusions or cardioversion, then you could bill for critical care. Hyperkalemia with IV insulin treatment. Now, there's some hyperkalemia where you're going to give them some oral medications, but if you give them IV insulin or IV calcium, then you can bill for critical care. Ischemia of the limb, bowel, or retina. This was reprinted from an old ACEP lecture, but this meets the criteria of a critical illness, one that, quote, an illness that acutely impairs a vital organ system and there is a high probability of imminent deterioration. Pulmonary embolism with heparin and admission. Now, if someone has a small PE that you discharge home with some oral apixaban, that's not critical care. But if you have to give the patient some heparinoid and admit them to the hospital, that usually satisfies the criteria for critical illness. Notice that all forms of shock meet this criteria as well. If the patient has an acute stroke with paralysis, not just paresthesias, that's a critical illness. Suicidal ideation requiring chemical or physical restraints typically meets the definition of critical illness. And finally, trauma with major injuries, such as a blood transfusion or intubation. Finally, people often ask, can you bill critical care and discharge patients? Well, there's nothing that says that you can't, so this is debatable, but it appears that many insurers will deny your critical care CPT code if they see a discharge to home order. They assume that if a condition is life-threatening, then you should probably be admitted to the hospital. Personally, I would only document critical care time if the patient was discharged home AMA or being discharged to hospice. In the next video, we'll discuss ICD-10 codes. They are much more important than you think. Please post any questions in the comments and I'll try my best to answer them.